listening to the Pharmacy Podcast Network.
This episode of Integra X Files is the second part to our conversation with Paul Baldwin. If you missed part 1, be sure to check it out at integraxfiles.com.
Welcome to the Integra X Files, a place where we'll explore and solve for the X factor that will help reshape the future of long-term care pharmacy. Join us to discuss topics and insights that will help you discover ways to grow your pharmacy, stay up to date on important legislative and regulatory issues, learn best practices for operating a profitable pharmacy business, and unlock the mysteries of technology.
So the topic we wanted to kind of pull the thread on is how do you expand your practice, right? So if you're a long-term care pharmacy, how do you think about where there's avenues for growth or to add on or to do more? And in part, it does go back to this where it's like, hey, as we see, drug prices being continually compressed and, more and more pressure to do the same amount of work for less revenue, how do pharmacies think about where else they find those opportunities? So I'll throw that out as the very broad question to you, Paul, and then we'll see where it goes.
I think this is a great topic because, this is right now. If I were 30 years younger, this would be a giant playground. This is like Disney World for a lobbyist or a health policy person, because this is a moment in history in which healthcare is poised to make a significant shift in some direction, and what direction that is, we don't know. But people, policymakers, citizens, other professionals realize that this tree of healthcare cannot grow to the sky. There's got to be a limit. We cannot spend 100% of our GDP on healthcare. Back in the years when, the Clinton administration, when they were trying to do healthcare, we were probably under 15% of GDP, and now we're pushing 20%. Nobody ever thought, back in 1992, 93, nobody ever thought we would get to this. We thought, okay, there's a natural limit to which, to what we can do to spend on healthcare. Something will intervene. Mm-hmm. And I think people say, someday it'll be 20%. Oh, no, we'll figure it out before then. Well, we haven't figured it out. And it's 20%. Okay, so something's going to happen. And, we talked before, healthcare costs are the product of unit cost times volume, utilization. So, something's got to give here. Okay, so when we look at the landscape again and we see, incredible frustration on all sides, people, look at the amount of money we spend on healthcare. We're not getting the best outcomes in the world, even though we spend the most money per capita. We've got, confusing healthcare rules and regulations. It's you talked about before how confusing and complicated the system is. But we're spending more than ever. We're not getting improved outcomes. There comes a point, and I think we're close to it, where people say, okay, this has got to change, and it's got to change in this way. All right, so this is going to happen, before too long. Now we look at long-term care pharmacy, and right now the long-term care business is becoming deinstitutionalized, and there's just nobody. I love the folks. I think some of the most dedicated healthcare professionals are around are people who run nursing homes. My mother-in-law was in a nursing home for months, and we used to go in there, and I just marvel at the quality of the people they had and the compassion they had, and just really dedicated people. But nobody wants to be in a nursing home. Nobody wants to send their loved ones to a nursing home.
No, and the pandemic made that worse, right?
Exactly.
People are scared to go and get stuck.
Yeah. 40,000 people in 40,000 nursing homes in New York State alone died as a result of being of COVID because of it was bad policy. We look back and say, it was probably bad policy, but it's you got vulnerable people all in close proximity what do you think's going to happen?
Right.
Right. And this is just not a good place to be. So, the move was already being made to deinstitutionalize healthcare. So we got home and community-based services. We got, a reliance on different, non-institutional places to go. We're moving, into we're going to be forced to go into different venues. It's not institutionalized business anymore. So, if you look at expansion, and look at all the different noise that's going around in healthcare in general, there are places to go that are proximal to us. Home care is one place. Home care is a roughly $130 billion business. There's 11,000 home healthcare agencies. Mm-hmm. And primarily, this is the interesting thing, though. Home care is primarily a private insurance reimbursed. They're not as dependent upon Medicare and Medicaid as we are as a long-term care pharmacy mm-hmm. businesses. 90% of revenue we get is based on state and federal government policy and regulation. So, in Medicaid and Medicare. So there's an opportunity there, but and there's hospice. Hospice is a growing entity. And there was an interesting, and I scanned an interesting article that I got through the National Library of Medicine that said there was talking about the impact of having a pharmacist engaged in hospice, and one of the observations was that pharmacists are really underrepresented in hospice. That if because remember, hospice is palliative care. It's supposed to be, we're not going to try to cure you. We're going to make you as comfortable as we can. Remaining days, and so it's medication intensive often, and it requires people who have the ability to properly manage potent medications. So hospice is another place, and that's there's a Medicare benefit for hospice, but private sector is actually more active. The other there are places that I've looked at. I'm looking at my notes here because I think. The other thing is I talked about this in a blog or a article I did in my usual monthly thing for the senior care pharmacists at ASCP, and they were interested in chronic care, how the federal government supports and encourages chronic care management or management for chronic diseases. And this is an area where there's, a fairly healthy Medicare reimbursement for physicians and providers who, and the fee-for-service side that want to engage in the management of people with chronic disease. But it's really underutilized. And I think about what the opportunities are there for an enterprising pharmacist to be able to go in and say, there's something here, there's something I can do, I can add value. The mindset of this whole thing, though, if you look in the private sector, and I'll just mention this because I don't want to forget it. One of the things that I think is a big opportunity, and it's outside of our normal areas of care, is the area of healthcare in the employer as an employee benefit. This is. I remember the reason this even got started, me thinking about this, was several years ago when I was at LTCPA. We were briefing a PR, a communications agency on our portfolio. They were going to do some work for us, so we spent a day talking with them about what So I was talking to them about what a consultant pharmacist does, mm-hmm. and the guy who's a seasoned professional. He was in his mid-50s. He puts down his dry marker and he looks at me and he says, "Say that again." He said, "These pharmacists, they go in and they check on the drug regimens for these people." I said, "Yeah, once a month." He said, my parents are well into their 80s. They're not in a nursing home. They live each other. He says, every time I go to their house and open their drug cabinet, my heart sinks because I don't know what those things are. Yeah. And I know they don't know what those are.
Well, and has the doctor, gone back and looked at everything else they're taking and looked at it holistically.
Or got from another physician that he doesn't know about. Yeah.
Yeah.
So the guy says to me, he says, I want to find one of the, I'll pay for this. I don't, this is, and now, okay. So now look at today. This is over 20 years ago. I'm talking now, look at today. Today, people are, employers are having a hard time keeping the employees satisfied. And we talk about benefits. And of course, benefits are something like 40+% of like big, Fortune 500 companies have what they call an elder care benefit for their employees. But when you look deeper into that, it's pretty thin. It's like a referral service. You need to find care for your, home care or nursing care for your aged, your mother-in-law or something. We'll here's a number to call and we'll help you out. It's like an employee, referral service or something. So it's not very well thought out, and it's not a very deep benefit, but they call it an elder care benefit. Now, today, 70+%, according to the Society for Health Human Resource Management, 73% of employees are caretakers. That sounds like a lot to me.
Yeah.
73% of employees have responsibility for taking care of an elderly relative. Mm-hmm. Now that may be full-time, part-time, whatever it is, but there's a significant number of workers that have responsibility for taking care of someone who's usually related to them. So this puts a huge amount of stress on the system, and they could document, how many times people who are employed take off from work because they have to, tend to the needs of somebody they have a caretaking responsibility for. So this is a big deal. And I'm thinking to myself, and I talked about this to a friend of mine who was our, VP of corporate benefits for the company I used to work for in the pharmaceutical industry. And I said, what is there a possibility for a benefit, an employee benefit that provided on demand, or as needed resources of a senior care pharmacist to be able to go in and take care of an employee's designated elder and review their medication, do a drug regimen review, talk to their physician about streamlining or changing medications and that kind of stuff. And the first answer he gave, I thought this was interesting because the first answer he gave me was, yeah, send me something on it, I'll find out. And I thought, okay, he wasn't really enthusiastic.
He wasn't listening. Yeah.
So he calls me a couple of weeks later and he says, that thing you sent me? He said, I talked to a couple guys. Something there.
Yeah.
And I'm thinking, really? I mean, his peers were Fortune 500 benefit.
There you go.
So these guys were, and he says, maybe you got something there. And I went on I was in a different place at the time, but I thought, wow, that's interesting.
It is. It's fascinating because I think one of the things I think about, as I've watched the industry since I started working in healthcare is, gosh, ACOs and accountable care and all of that was all the rage of the talk, the early 2010s.
Right.
And if you look at how many organizations truly are an accountable care organization now, it's not that many. It hasn't changed dramatically over that time. And in my head, one of the missing links is pharmacy, right? If you're a physician's office and you're saying, hey, I'm going to be accountable for this population of patients, how much of making sure those patients are healthy and successful is dependent on they take the right medications and they take them on time and they can afford their medications. But there's such a massive disconnect in the data and the operations of those physician practices and pharmacies. So I've thought the same thing where whether it's the pharmacies sort of partnering with an employer or partnering with a physician practice or partnering with somebody else to make sure that, hey, those really high risk patients that are on a lot of meds, that there's that kind of communication. You might actually find that there's, accountable care type dollars available to pharmacies to do that type of work.
See, and that's the thing I think is it's super exciting about all this, because I think the payers are now, they're in a mood to listen more than they have been in the past, because they have an economic incentive to, if anybody even has a potential promise of stopping the bleeding, they're willing to listen and pay attention. So, imagine this. I mean, just to riff off of that concept. What if, if I were a physician, if I were a primary care physician, patients would be in trouble. However, imagine I were a good physician. What I would most likely do as a practice setup is that I would get, have somebody who could give a good history, let's get a good history on the patient to remember we capture everything and do an exam. I would give a diagnosis, and then I'd stop there. I'd send them to my in-practice pharmacist, who would then say, all right, based upon my understanding of, you have diabetes, type 2 diabetes, you got hypertension, whatever the thing is, based upon the combination of cost and efficacy and convenience of use and all these kind of factors, let's have a conversation about what we could do. You have a conversation with the patient. This never happens, by the way. I mean, you get a script from your physician. You're lucky if they tell you what it's for.
Yeah. Yeah. And they don't have the information to have a conversation about cost with you. Like they don't have it. Right. So you send the patient before you leave, stop by the pharmacist who's next door. You'll have a consultation. If necessary, if the state doesn't allow you to prescribe, the pharmacist will send me a note. I'll sign the script. You'll go to your Rite Aid or your CVS and pick it up. That's the way it ought to be done. Yeah. I mean, now there's lots of reasons why it's difficult to do that. I mean, most of it's, turf issues with physicians. But this all starts at the state level. I mean, the states control, physician medical practice and pharmacy medical practice. They're the ones who say, hey, if you're a registered pharmacist with these qualifications, you get to prescribe. And it's not the federal government, it's the states that do that. I always go back to, it can change everything. I go back to an example. So when I was at McKesson, we worked a lot with the University of Wisconsin. And they have, within their healthcare system, they have a pharmacy. And the laws there allow that pharmacist certain levels of prescriptive power under the guidance of the physician. And so, they do transplants is one of the big things that they do. And for transplants patient, they'll basically say, look, wherever you are, you're going to get your meds from the rest of your life from our pharmacy. Because that pharmacist can work with the patient then on all those. And it's such a delicate surgery and a delicate balance to make sure you got the right mix of meds for it to be successful. But it's the pharmacist who can do that and who can make those adjustments. And so it really is like you see that path happening more in the hospitals where the doctor can prescribe pretty generally and the pharmacist at the hospital can make the specific, choice of med or choice of dose based on what the patient needs. But it's like that hasn't translated in any way to the retail or the long-term care world really yet. And I think, it takes this is a lot of this stuff is not really, if it has been tried, it's been tried at, at a local level or, somebody has written a paper about it, says, this stuff works. But if you're going to be a pioneer, I mean, this is where we need to change our minds and change our outlook, because if you're going to be a pioneer, now you guys are in the technology business. And this is, I mean, your industry has a reputation for, thinking big, making bold, bold moves and doing stuff that we never, I always tell people, when it comes to taking care of consumers, I said, I guarantee you, nobody in the year 2005, when asked what they would want most to help change their lives, nobody described a handheld device that would connect them to the internet. It's the old Ford, movies. If you ask people what they want, they say a faster horse. They don't say a car, right? Like you got to think differently. And Steve Jobs was right. He said, it's not the consumer's job to tell us what they want. That's our job. And that was a brilliant thing.
It worked.
And that's in healthcare. We need to come to that mindset where we say, okay, this is what we need to do. And I think it must be frustrating for technology people to have to, and a lot of people have been frustrated. You see, it looks to me like Amazon and you know, the big Google and the big tech companies, when they decided they wanted to get into healthcare, they didn't realize.
They didn't understand how, you know, I'll go back to my statement of it is the most complicated industry I've ever worked in. And so I sort of chuckle to myself every time I see one of the big tech companies say like, we can totally come in and fix healthcare. Yeah. And then 4 years later, they're like, yeah, we've shut down the business because we realized we couldn't figure it out.
That's right.
And I joke all the time. I'm like, until you figure out how to interface with a COBOL, you know, claim system, good luck to you, right? Like you can't put an iFile on a COBOL.
Yeah, we used to say long-term care pharmacy was the second most regulated industry after nuclear.
Yeah. So I'd believe that.
You know, we used to say that about pharmaceuticals, you know, how regulated we were. Yeah. And, you know, but the whole system is, you know, regulated beyond reason. But, but again, this is the perfect time, because I think we're going to see the sort of, not desperation, but the sort of, you know, looking at where we're headed. There are going to be people, even who may be by nature less creative and bold than we would like them to be, who are going to say, listen, I got to do something. This sounds reasonable. Yeah. And even though there's lots of reasons why perhaps, you know, we shouldn't do it, we got to do something. Yeah. Let's try this. And so I think that's the beauty of the timing. I mean, this is an incredible time to be in the healthcare business. And pharmacists are pharmacists are in the perfect spot.
Oh, they are.
They're the most accessible healthcare professionals.
By far.
They are in the community. I mean, from a political perspective, 60,000 pharmacies in the United States, 300 and some odd thousand pharmacies. There are not 60,000 PBMs in the United States. No. There are not 60,000 hospitals in the United States. And, you know, very few members of Congress have a PBM in their district. Every one of them has dozens of
pharmacists.
Yeah.
Yep. And that's, you know, we need to be able to flex our muscle in that way, but do it in a way that says, hey, we think we can save. Now, historically,
that's it. You got to hit the thing that they care about the most, which is how are you going across?
In the past, you know, when I started my career in policy and advocacy, I was always, I mean, I was butting heads with the pharmacy industry. I mean, back in the early 2000s, late 80s, or, you know, 90s, primarily the 90s, the pharmacy industry was suing manufacturers over access to price discounts, you know, Robinson patent violations, all sorts of stuff. Mm-hmm. And, you know, we in the pharmaceutical industry were, you know, we had this hate relationship. We were, but, you know, that seems to have, you know, that's water under the bridge now. We've learned to coexist, but, you know, pharmacy historically has not exercised its muscles. When it does, it does well.
Well,
I mean, politically and from a policy perspective. The one mistake, though, that sometimes we make is that I cringe when I'm in these meetings and somebody will explain what they're doing that's innovative, and then somebody from the back of the room, usually an old guy like me, says, "How do you get paid for that?"
Yeah.
And, you know, and there's a lot of talk among the consulting class or the professional, you know, business consultants who always talk about never leave money on the table.
Yeah.
Well, we got to leave money on the table. You know, Costco leaves money on the table. Amazon leaves money on the table. That's why they're Costco and Amazon. Somebody coming along. Remember, you know, it's unit cost times volume that makes healthcare costs. Somebody's going to have to be willing to say, first of all, you know, we're going to automate everything we can automate. Yeah. Second of all, we're going to use our brains to figure out how to deliver valuable services at a cost that doesn't break the bank. And we'll be able to do that with the innovation and the scope of services that we can provide as the pharmacy community. I mean, this is huge. I think this is huge opportunity.
Yeah, I always think there's that old saying, in crisis opportunity.
Yeah, right.
And this is one of them. It's like, we'll reach a crisis point at some point in healthcare where the costs just truly are unsustainable and care suffers for it.
Yeah.
And so how do you innovate now? And how do you think of the different, whether it's, healthcare in the home is a great example of like, look, we're not adding long-term care beds. And the population is aging.
Exactly.
So there's got to be an answer that's not just an incremental long-term care bed.
Yeah.
So how do we not let this crisis go to waste?
Yeah.
That's right.
To say, hey, we can provide, comparable or better care at a lower cost and do it in a way that patients are happy and as healthy as they can be. And we can manage the cost. Yeah.
Yeah. What's big opportunity, and listen, I mean, one of the big issue now, I mean, the headline issue for everybody is, artificial intelligence.
Yeah.
What are we going to do with artificial intelligence? I think, as I put this on in the last blog post was, what would you rather be? Would you rather be, a consultant pharmacist, or would you rather be a consultant pharmacist who knows how to use AI?
Yeah.
These
it's
are
huge.
tools.
Yeah. And it is absolutely a conversation, we're having internally right now around how do we use it. And I think of two things in healthcare, right? One is, I always say, it's like healthcare at some point will just leapfrog technology because we can't keep up. It's like we can't possibly march through all the generations that have existed. But the folks will be successful are the ones who can figure out how do you leverage the newest stuff like in AI while working with technology that's 40 years old, because that is the reality of the industry, right? There are, and I don't care what part of the industry you're in, right? There's technology out there doing really meaningful stuff still that's easily 40 years old, not older. And so you've got to be able to and this is where the big tech guys struggle because they just live over in that, what's the new fancy thing? It's like, you want the new fancy thing. And to make the most out of the new fancy thing in healthcare, you got to be able to use the new fancy thing with a COBOL system.
We rely on, we still use fax machines.
We still use fax. I joke, the last company I was at, we did Medicare enrollment, and I was like, it would appall people if they truly knew how many Medicare enrollments were still done completely on paper. Would horrify people.
And faxing is HIPAA compliant. That's why we do it.
That's the thing. That's the thing. It's healthcare and lawyers, man, keeping faxes alive.
Exactly. Yeah.
So I just think this is a great subject. And I think, I'm excited to see what people do with this. I mean, we have a lot of innovators, and I meet them all when I go to ASCP meetings, and I think, but these guys are really smart. They're creative. We've got people all over the map. I've met, women that were looking at exactly this. The idea of how do we embed ourselves into primary care, and I just think these people need to be encouraged. These people need to be publicized, and we need to lionize these folks, because these are the people that are going to take us to a
change.
Place that, we can
it is a mindset shift. I mean, I laugh because when I first joined healthcare, I hadn't worked in healthcare, and you get the benefit of this industry is doing this. Why don't we do it that way? And you come with some fresh ideas, and then you work in healthcare for a long time, and you become the person in the back of the room who's like, well, you can't do that because of HIPAA. And how do you get paid for it? You can't do that because of this regulation.
Yeah.
And I think of that it's, one of those cliches I say all the time of that improv lesson of you don't say no, but you say yes and. Yeah. And we need a little more of that in healthcare, of saying okay, yes, that's a really good idea.
Yep.
And we have to think about this, and how do we make it work?
How do we get to the end? Yeah. That's right.
Yeah. Great. So tons of opportunity, and it's it's a maze to figure out how you get there, but has to be done.
Yeah, I mean, and it takes curiosity. I mean, and it takes a thick skin. You have to be willing. We've heard these sort of Horatio Alger stories where people have been turned down hundreds of times, and then finally they get their break and they're become, legendary. We have to be, have to have that kind of resilience. If we say, and be focused on the end result, I'm determined to find a way to make healthcare accessible, less expensive. And that's sort of my mission in life.
Yeah.
And even I have to find a way to get in. But it's like pushing a rock, getting started is the whole thing. I mean,
exactly.
I used to, I'm a private pilot, like,
fun.
Ed Vess and I are always talk about, flying airplanes. Having crashed one a couple of years ago, I'm less of a pilot now than I used to be. However, I always talk about, you take a 3,000 pound little, private airplane and you start from zero and get it up to the speed where you need to take off. I said, that engine is just like screaming, saying, "Oh, this is too much. This is right." Yeah. Then you finally get airborne, and everything
quiet down.
It's quiet, and the engine, you can pull back the throttle on the engine a little bit, give it some rest, but getting from zero to takeoff speed, is that's like that. You got to have that mindset. I said, I'm in that point where I'm about to launch. Once I get up, things will get better. Yeah, be able to work through that. I mean, everybody who's started a business has been through that.
Exactly.
Yeah, and I think the thing I've heard from talking to startups and about VC investors in healthcare is it also is just it takes longer in healthcare. So if you're and that's a sort of a message I've heard them kind of deliver to other investors, which is, hey, if you're investing in a startup in the retail space, whatever, like, you're probably fine and you can expect a return if it's going to be successful in X amount of time. And if you're in healthcare, double that. Yeah. So you've got to be that, you're launching a big old plane. Like, you got to be a little more patient.
You need a longer runway.
You need a longer runway
that's good.
to get that thing in the air. And so some investors just aren't patient enough to get to the point where the money comes.
I'm wondering about investors today. Are they patient enough to work through that process? It's all about me. It's immediate today. I want immediate results, and I'm not sure people are willing to wait that long or divest that time.
I think if they look at the experience, I mean, as Francis was saying, look at the experience of the Amazons and the Googles and the Apples and everybody else who's decided they want to be players in healthcare, and they inevitably at some point in the mid to near future, they say, "Wow, this is way more complicated.
This
is really hard." Yeah.
And so I think anybody who's experienced in investing in technology and healthcare will say, will have to have, if they're going to be successful, they have to temper their enthusiasm with some realism and say, this is going to be patient. I'm not going to be able to flip this in a couple of years. This is going to be a long haul.
It's a long play. It's a long play. Yeah. So Paul, one of the things we do in our podcast, I see Jim nodding at me.
Exactly.
We always ask folks at the end, what's the X factor? What's the thing that our listeners should take away from this call and go do differently when they get up and go back to work tomorrow morning?
Well, one thing, that's good. That's good to try to make me focus.
Right? I'm going to narrow you down. What's one thing?
Okay, the one thing.
Your runway just got shorter.
The one thing I think is to be awake, pay attention, look at the opportunities. The opportunities are right in front of your face. You're not seeing them. Now, we've talked about expanding your business. But the same thing is when it comes to automating what you can automate. If we're going to be successful in becoming, reliable healthcare partners, the repetitive stuff that we do every day has to be automated, and we need to get on with it in a relatively. Nobody wants to pay a retail pharmacist $125,000 to count, lick, and stick. That is not a sustainable.
You've had a heck of a lot of education to do just that.
Yeah. Right.
So let's figure out how to automate anything that's repetitive, anything that's, that can be automated, automate that, then free up your resources to think about, how do we leverage all these technologies? But number one is pay attention. look for opportunities to automate anything. Oh, we do this all the time. We do it every day. We do it 1,000 times a day. Well, you should automate that or figure out a way to automate that. Second of all is, what's my customer? What are my customer going through? That often will tell you what the next opportunity is. I mean, my customer's having issues related to keeping staff. Well, maybe that's an automated issue. Or, maybe, you look at the managed care space and they're saying, chronic illnesses are costing us an uncomfortable amount of money. Well, we think we can help with that. But your experience, I tell you one of the most revelatory things for me was helping a senior citizen straighten out this person was 87 years old, confused. They kept getting bills from the hospital for 2 hospitalizations they had the year before. And he said, I have no idea what I owe. Can you help me? And I said, yeah, I think I can. So we did. We went through and he thought he owed him like $6,000. And I said, by the time we got through dealing with the hospital, I said, you owe him $1,800. Can you do that? He said, yeah, I can do that. I can't do 6,000. I can do that. Yeah. And he said, I can sleep at night. All right. Well, that's a good thing. But the thing is, for me, I got a picture of how people interact with these. I mean, these are not consumer friendly things.
No, and there's that theme of consumerization in healthcare, and I'm like, good luck, because it's exactly that. No, that's right. Really hard.
But anybody who does this ought to be required to take a senior citizen under their wing and say, we're going to figure out how to do this. Let me show you how to do this. The other thing is, you just look at the. I know this was this is one thing.
Yeah. This is the problem. We could go. We're just gonna have to have you on for another episode at some point.
I love this stuff.
Part 2.
And we'll start that episode with the story of the plane crash, which I'm both scared and excited to hear about.
Yeah. Well, I've made a good story out of it. So,
good. Well, hopefully you're here. So that's we know there's a decent ending at least.
Yes, there is.
Perfect. Well, this has been super, super fun. We really appreciate the time.
Thanks for listening to the Integra X Files. We'd like to hear from you and gain your perspective on the X Factor in improving long-term care pharmacy. Connect with us at integraxfiles.com. That's integraxfiles.com.